Well, hi everyone, and welcome into Pushing the Limits. It's fantastic to have you with me again today. Now, I have Associate Professor Dr. Mr. Edmund Leung. Welcome to the show. It's fantastic to have you here today, and thank you for your time.
Thank you very much.
I'm really excited for this conversation, and we met because I brought my mum to you, and so you've been looking after my mum, and then we got into a bit of a chat, and I thought, well, I'm going to take the opportunity to see if I can get you on my show, because I've never had a gastroenterologist on my show. Can you give us a little bit of your background and tell us how that you ended up in into gastroenterology as opposed to something else?
Well, that's really a long story. I always want to be a doctor to begin with. And then I think just throughout my training, I had very good mentors in my field. And you kind of learn and become loyal or appreciate their work. The people who are really good to us, the mentors that were really good to us. So I kind of followed their path. That's how I became a what we call GI surgeon, a gastrointestinal surgeon. So yes, I'm a gastroenterologist, but I'm also a gastrointestinal surgeon, which I do the operations as well. And that's how I end up being in my field. Mm-hmm. But it's also just a fascinating subject because it's such a wide spectrum of conditions anyone can get. So I cover essentially the entire abdomen. So a gastroenterology really is a study of the entire digestive tract from mouth to back passage. Mm-hmm. And also you get the liver, the gallbladder, pancreas, they're all interlinked. And we can always talk about how they're interlinked together with the microbiome later. But essentially, it's a big topic of medicine. So I thought it covers quite a lot, and that's become very interesting for me.
Wow, that is, and having all of those interconnected systems, that must be an awful lot to learn. And being a surgeon, you're having to actually do the surgical stuff. That I've always wondered, what is it like to be a surgeon? Because for most of us, have never been in and had an experience like that. To have to operate on somebody is quite a daunting prospect. How does one overcome one's fear to do such a thing?
It's interesting. I never had the fear of operating. And certainly when I was in med school, I saw medical students fainting, doing just cadaveric dissection of cadavers, donated bodies. But I actually found the anatomy and the structures and the art of surgery very exciting and very interesting. So I never was fear of it. And I became more and more excited about how sometimes surgery can fix certain problems. So for example, cancer is a good example where often, and we still mostly believe in it. I know we can talk about other ways of treating cancers, but still, I think majority of cancers are still being successfully treated by surgery. And that feeling is good when you can actually remove something that is harming people.
Yeah, absolutely. Absolutely. So let's dive into then a little bit about if you were to talk to someone and, if you were to talk to a class of young people, and you were trying to give them some life advice, as a surgeon and as a gastroenterologist, what would you be saying for them to be on the lookout for, things that they should be screening for, things that they should be aware of, and ways that they can take care of the digestive tract?
That's actually a very, very good question. So in terms of looking after themselves and screening, I mean, obviously exercise and healthy eating, these are basic things we all know about. So screening is not just about what the doctors can offer anyone on the street. It's about self-awareness as well, looking out for symptoms, because even that diseases of digestive tracts happens in young people too. Classic example, inflammatory bowel disease. They can happen as early as teenagers. And they just need to look out for symptoms, not ignore it, and early awareness and early medical attention seeking is quite useful. So as a gastrointestinal doctor or surgeon, my first role actually is to rule out things that we can treat medically or something sinister. So a lot of patients that come to me, actually the most important for them is reassurance that they have not got cancer. That's actually the most important thing. A lot of these patients, once I've ruled out cancer for them, they're quite happy. They don't want, they're quite happy to put up with the odd tummy pain or the odd loose stools. They're quite happy with that as long as they know they haven't got cancer. Of course, there are many causes of their symptoms, but that's my first role, is rule out sinister things.
Mm-hmm.
My second role is rule out simple conditions or diseases that I can treat medically.
Mm-hmm.
And this will be, I would say, about the 20% of patients that I see. The other 80% of patients I see are usually non-specific symptoms, or we describe it as irritable bowel syndrome.
Mm.
That term I have to use very cautiously and carefully, because I do believe that term is loosely used.
Yeah.
Because when we haven't found a diagnosis, we blame IBS.
Mm-hmm.
But have they really got IBS? Or is IBS actually just a set of symptoms
Mm-hmm.
because of other conditions? So that's something very that I have looked into over the years, and how to manage them, exclude other minor conditions, and target treatment sometimes is what we need, rather than just say we'll take some paracetamol and live with it.
Yeah, definitely.
Yeah, that's really my main role, and that's what I would tell to anyone that I see is, depends what you want, what your expectation is as a patient. Do you want to just be reassured that you haven't got cancer, or do you actually want to know what's wrong with you, and optimize your lifestyle and optimize your symptoms? And that's what really I need to get from them.
And with IBS, and irritable bowel syndrome, and there's the ulcerative colitis and the Crohn's and this family of problems, and it seems to be quite prolific. Like, there seems to be quite a lot of people who are dealing with this. And what is the difference between, say, an ulcerative colitis and a Crohn's and an IBS and an IBD? I've struggled to sort of differentiate between these.
So IBS is actually just a set of symptoms. Is what is defined as a functional disorder of the digestive tract. It's actually defined based on symptoms only. Mm-hmm. So there's no confirmed diagnosis as such. You can't take a biopsy and say this is IBS.
Right.
It's a functional disorder of digestive tract, and they define it based on chronic abdominal pain, bloating, and change in bowel habits. And most important definition is there's an absence of an organic diagnosis. Mm-hmm. There's no confirmed diagnosis. That's what we talk about, a constellation of symptoms without a diagnosis, is what IBS is about. Whereas IBD, which is inflammatory bowel disease, which consists of many forms: colitis, ulcerative colitis, Crohn's disease, and microscopic colitis. These are defined medical conditions where you can actually prove and diagnose based on biopsies. But very interesting, if you talk about the cause or the causes of IBD and IBS, there's a lot of talk about gut health, microbiome induction, and genetic predisposition as well. So whether or not they are interlinked in that sense, that's difficult to know. But IBD has a defined organic cause, whereas IBS is just a constellation of symptoms without a cause.
And I think the microbiome, from my perspective, doing microbiome testing and looking at different markers within the microbiome system can be hugely beneficial to people's health. And I certainly believe and have used it with my mum extensively, as you know, and to try and give back and put back in the right things, take out the wrong things, and do all of that sort of stuff. So some of the markers, things like zonulin and leaky gut, and the work of Alicia Fasano, and are you aware of any of those sorts of things like zonulin and leaky gut, for starters? Is that a thing that's on your radar?
Absolutely, absolutely. I think a lot. I mean, going back to IBS, the leaky gut theory on IBS is very much well studied now and better understood. I wouldn't say well understood, better understood. So So we call it dysbiosis of the gut. So dysbiosis simply means an alteration of gut bacteria within the systems. I describe it as more bullies or bad bacteria and overwhelming the good bacteria in your gut system. So what happens is that it stimulates, so what we call this dysbiosis or dysfunctional microbiota, that's how we describe it. It increases the immune response to within the gut system and affects the gut brain. It makes the gut more leaky, as you described, it becomes more leaky. So by having more leaky gut, all these bad bacteria, all these bullies come out, and the body got to deal with it. So your immune systems then starts targeting these leaky gut, or medically defined as translocation of bacteria, of antigens, the metabolites. It triggers a whole host of immune activation. So it makes your body always in battle, always consumed. So people are tired, they're always in pain, achy rather than in pain. They feel like they've got flu-like symptoms. They're just under the weather all the time because a constant battle between your body immune system against this leaky bowel. And then you get this discomfort. And of course, all these systems makes you immunocompromised. And then you're more prone to other illnesses like colds and flus and viruses. And at the same time, chronic symptoms, makes you unhappy, but at the same time, these immune activation of leaky bowel actually stimulates a hormone in your brain we now know is corticotrophic releasing hormone factor, which affects your overall mental health. So and that viciously, like a vicious circle, then increases the gut motility. And make the gut more leaky. So it's like an exacerbation of problems. So yes, they're all interlinked. The leaky gut theory is actually very well better understood now.
And there's things like lipopolysaccharides, which are on the from what I understand, the outside of the bacteria, the gram-negative bacteria, I believe.
That's right.
and they come out. And it really accelerates the aging process and the aging of organs is what I've been reading about lately. And so this is like, we've been studying, I have a biotech company, we're doing immunosenescence as our target that we're going after, looking at slowing the aging process through optimizing the immune system. And we're looking at agents that can help with that leaky gut side of the scenario so that we can actually slow the aging process down. And that the immune system, there's like 70 to 80% apparently of the immune system is in and around the gut and very much influenced by what's happening in the gut and what's happening outside of the gut or coming through out of the gut. And so anything that's immune related, and of course, this is the gateway to hell. Like if we start to have immunosenescence or the aging of the immune system and the landscape of our white blood cells and our CD4s and CD8s and all of those sorts of things start to change, then we're going to be at the mercy of so many of the diseases of aging, and that this chronic low-grade inflammatory state that so many of us are walking around with is actually contributing to the speeding up of our aging and the speeding up of our demise, basically. So it's that important, really.
Well, obviously, it's actually what you're describing is exactly what is happening. It's a chronic. I call it like a chronic battlefield.
Yeah,
the body's always in battle with itself, with the microbiome, the bad ones, and you're absolutely right. If you keep your car running non-stop and never switch off the engine, of course your car's going to have a short-lived lifespan. And that's exactly right. You are a body, you have an aging process, but you're constantly fighting chronic conditions, or chronically battling. It's like chronic inflammation.
Yep.
Naturally, your body is tired, knackered, and your immune system, you're aging quicker. That's just that's quite a natural process. Interesting, you mentioned lipopolysaccharides. I didn't think many people would talk about LPS.
Oh, we do.
I actually did my doctorate. I spent a lot of time studying LPS in my doctorate degree, actually, as it happened.
Wow.
I didn't know I didn't know that you know about LPS because I never talk about it to anyone else because they wouldn't understand it. But LPS is exactly right. It's a gram-negative. It's an antigen that or protein that's produced by gram-negative bacteria. It just is so potent. This antigen, it really stimulates a severe immune response, complement response in your body. And LPS is found in good bacteria as well. But the good bacteria that sits in the gut, if you've got good gut health, they don't leak out and they stay in the gut, and they do the job by keeping balance of your immune system. But it's only when it starts leaking out everywhere, or overgrowth of it into the small bowel, in the case of SIBO, that's when you start causing symptoms and wearing the body out. It's so potent that actually LPS is well recognized now, that it speeds up the cancer spread process. And that's where my doctorate was really about how LPS actually promotes
a cancer environment.
Spread, promotes growth of things like polyps in the body and things like that. So and actually promotes migration of tumors. So it's actually one of the better studied protein amongst the microbiome data. So you're right about LPS. It is actually one of the most potent antigen that you can get in that gut.
Yeah, and I think don't quote me on this, but I believe there's an actual test now that we can test the levels of LPS, at least in America, not necessarily here in New Zealand. Is it? Have you heard anything along those lines?
LPS it's interesting. I'm not aware of commercial testing for LPS. Because we tend to just measure the overall bacterial load, and then you can guesstimate how much LPS is available to be released, I guess. LPS is certainly available in the laboratory, because I used to test for it. Even when I was a youngster doing my doctorate degree, I was testing LPS levels.
Wow.
So that can be done in a laboratory setting on cells, in a test tube.
Yep. But
in terms of commercially available testing, I'm not aware of any, to be fair. But I don't see why it can't be. If it can be done in a lab, why can't it be done commercially? I guess it's just calibration and quality assurance. But it's not that important to measure the actual LPS level. I think if you're able to measure the bacteria, the microbiome data in your body, that's good enough to estimate what your risks are, because the LPS is not the only one. And there's a synergism between LPS and other microbiome as well. So actually it's more useful knowing what you've got in your system rather than just LPS levels, because it doesn't work on its own. It needs to work with other proteins to become potent. It's a synergism. They work together to exacerbate their effects.
And when they're on the inside, they're actually okay. But when they get this, when this leakiness is going on, and we do complete microbiome mapping in our practice, and we look at things like, secretory IgA and zonulin levels, obviously, and the pancreatic elastase, and the health of your digestive enzymes and what you're doing there. Are you breaking your food down, as well as the actual populations of bacteria? And there are many microbiome tests now available on the market, and there's lots of arguing and fighting who's got the best one and who's, and it's an evolving science. And I think, but it really provides a good picture overall, I think, for people, just places to start working on. One of the other favorite things that I like to look at is things like secretory IgA, and also your short chain fatty acid production, how that's doing. In particular, butyrate is especially important. What's your take on those two, like secretory IgA and butyrate?
Wow, I mean, I wonder where you just read my doctorate thesis. Butyrate was another marker that I studied against LPS. It was very interesting that you described. I studied a long time ago. Yes, absolutely. The butyrate is, again, I can only speak of in the test tube, not in human. I have no real evidence in human bodies at the moment. I'm sure someone is doing studies on it. But butyrate actually suppresses quite effectively the activation of LPS. So even though LPS is released, butyrate actually suppresses the process how LPS activates a complement system and the immune response. So you release the IgA will be lowered by having butyrate around. But butyrate itself is a toxic chemical, so obviously you can't just give it to people as drugs. But butyrate is a chemical well known to suppress all that process. Now, I want to be specific. I suppose I think prevention is key rather than firefighting.
Mm.
The important message about having bacterial overgrowth or abnormal microbiome is probably best to just avoid that scenario in the first place, rather than treat the damage that's caused. So, for example, so there are many conditions. There are many conditions. So there are many conditions that can promote bacterial overgrowth. So, for example, some people, I recently had a few patients who actually had diseases which causes that, like too much bile acid in the system, like the pancreas is not working very well, like you were talking about pancreatic elastase. So if you actually have pancreatic insufficiency or dysfunction, you have not enough proteins being produced in your pancreas. So the food you eat then promotes bacterial overgrowth. And
it's
therefore,
not being broken down properly.
Yeah, so actually the treatment is not to give you antibiotics and treat the bacteria, it's to actually treat your pancreas in order to reduce bacterial overgrowth. That's probably more useful. And I can give you a case study. I recently had a patient who was labeled IBS for 6 years, going to the toilet 10 times a day. Everybody says to you, oh, you got bad IBS. She was only in her early 20s.
Wow.
Bad IBS, they've excluded all the big disease like cancer and Crohn's disease and colitis, but labeled her IBS. And then she went into looking at a microbiome because she was so desperate. You know, she couldn't even wake up in the morning and go to work because up to the toilet all night. And the microbiome showed that, yes, she's got a significant amount of bacteria, bad bacteria.
Yep.
And SIBO, small intestinal bacterial overgrowth. And then I said to her, well, why would a 20-year-old who's exercised well, eats well, do all the right things, have this condition? It's odd. So instead of treating the problem with antibiotics, I actually looked into her bile acid levels.
Wow. And
that was when I realized that she's got malabsorption of bile acids, which means that whatever she eats, she's feeding the bacteria.
So the bile acids are not coming out properly and they're not breaking it down, because it's a very antimicrobial substance, bile acids, and something that
Correct. The body balances out, obviously. It doesn't kill everything, but it kills a good number of them. And exactly, so they're not killing the bacteria, not digesting the carbohydrates she's eating, and that carbohydrate is feeding the growth of bacteria.
Yeah.
So all I did was I gave her one prescription to boost her bile acid absorption. I literally cured her symptoms from going
after 6 years of searching.
6 years of desperation.
Oh, poor
being labeled IBS. It's just a good example I always remember. I think we just need to think a bit deeper about sometimes dysbiosis is actually caused by a medical condition. They are interlinked, and that's an important message. It's not about treating the bacteria, it's treating the cause of the dysbiosis.
Yes, and yes, that's something that's been on my radar immediately, is always to look at things like, ox bile and TUDCA and things, even like natural substances that we can use to sort of support that bile production, because without that, it is going to get that overgrowth going, that small intestinal bacterial overgrowth. But then there's the hydrogen side and the methane side, and there's, again, arguments out there in the world about how to diagnose this and different aspects of dealing with SIBO. Anything that you would advise there? Like there is, the hydrogen dominant and the methane dominant SIBO. Is there any difference between the two from your perspective?
Yes, there is. But I think the important message, again, even with diagnosis of SIBO, my first and foremost discussion with any patient who comes in with symptoms of suspected SIBO is to make sure there's no underlying cause of SIBO. Why is it? So, for example, there are people with slow gut transit. There's people who are diabetic. And even sometimes they're born with an abnormal anatomy in between the small bowel and large bowel, with significant reflux of large bowel contents back into the small bowel, and then over time they colonize the large bowel bacteria into the small bowel. And also some medications can cause it. So those are the reasons I need to really look into to make sure that there is no simple reversible cause of SIBO.
Yep.
So I treat the cause of SIBO first. Once I know I can't do any more in terms of the causes, then I target a SIBO treatment, which can range anything from anything as simple as cutting out the carbohydrates, what we call FODMAP diet, low FODMAP diet.
Yes,
with probiotics. Sometimes I give a combination of, in over a course of a month, I give a course of antibiotics between probiotics to balance things out a bit. And sometimes it gets so severe, I actually give them bowel prep, as in the stuff they clean you out. There's very good studies on how, not just laxatives, I'm talking about proper bowel prep that you take and you just
for a
clean
colonoscopy.
But like a colonoscopy bowel prep, actually resets the body system. And I have many examples, many good patients, good cases that actually after bowel prep, they don't look back.
That was interesting to me to learn that about colonoscopies and bowel prep, that can have positive effects for people who are dealing with issues. And then I was looking into the possibility of getting a vitamin C prep, and when I actually asked you about that, I think you were quite surprised that I'd asked for such a thing. But the studies that I'd looked at were that was less detrimental to the microbiome if you were trying to spare the microbiome. But
you're right. I mean, I'll talk about colonoscopy in a minute, but the vitamin C thing is actually quite another interesting hot topic that's been well talked about, not amongst the doctors, not amongst the digestive doctors and surgeons, but amongst the anaesthetists, because now there's a big topic about vitamin C in control of chronic pain. Again, we talked about how microbiome affects causes pain, aches, general pain. And if you already got conditions that give you pain, actually bad dysbiosis actually exacerbates the pain that you already have, giving you more pain. So instead of just shoving you painkillers, which a lot of times we do, actually vitamin C is now known to augment the existing painkillers using the microbiome theory to control chronic pain. So that's quite a big topic now.
Is it oral supplement form?
Or injections. It's certainly a big hot topic upcoming.
That's interesting.
It's still up for debate because some studies have saying there's no evidence, and some said there is some evidence. So it's ongoing, the research, but it's a very interesting topic that I was just talking to Anissa about it recently. For palliative care patients, someone who's actually got terminal cancer, and she had nothing to lose. She's just popping painkillers all the time, affecting other problems. And actually she swears by that vitamin C was helping her.
I've done a deep dive into vitamin C, intravenous vitamin C for cancer and for sepsis and other things. And I've used vitamin C for mum and intravenously for over 8 years now, since her original aneurysm, and we're having one today actually. And the quality of life for cancer patients, there's actually quite a lot of research around it being a good adjunct therapy for cancer, or certain cancers and some cancers, and obviously with the doctor's approval and so on. But for quality of life as well, for pain management, I've seen that as well, and so that's interesting that coming from a gastroenterologist, I wasn't aware of that. Is the oral form of vitamin C any use? Like the intravenous form of vitamin C has a different mechanism of action in the body in huge doses.
It is. The problem with intravenous vitamin C for palliative care patient is that because they normally have a long line stuck in them anyway for other drugs. So it's quite easy to give the vitamin C intravenously. Oral vitamin C is being studied for chronic pain patients who don't have lines. I'm talking about patients with chronic back pain, chronic joint pains, fibromyalgia, muscle ache, that sort of already existing painful conditions. And then vitamin C oral augments the existing painkillers. That's still a study ongoing. Like I said, the data is controversial. Some papers swear that it doesn't work at all, and others saying it's got some benefit. But what interesting, you talk about quality of life, and that's the quality of life measures actually does say that oral vitamin C does help to augment the chronic analgesia,
Mm.
which, as far as I mean, the side effects is virtually none.
Yeah.
I can't say for sure none, but
A little bit of
it's not
gastro.
been well reported, put it that way, because I'm
Yep.
not a pain specialist. So as a personal opinion rather than a professional opinion is that I see no harm, but as a personal opinion, not a professional opinion, because I'm not a pain specialist.
Mm-hmm.
In terms of palliative care patient, I support it in
Yep.
terms of vitamin C. So going back to the colonoscopy, so colonoscopy is still the gold standard test for excluding bowel diseases. That's still gold standard, because the CT colonography can really only tell you whether there's a big lump or not, whether there's a big polyp, whether there's
That's
a cancer.
what we're looking for next week.
Looking at those things.
Mm-hmm.
But it doesn't pick up ulcers, it doesn't pick up inflammation. So it depends what you want to look for. If you simply want to rule out cancer, which a lot of patients do, then actually that's quite a good test. There is now a stool test available, which we use for bowel cancer screening. Not commercially available, sadly, because you can do that you can just get one in Europe or Australia.
Wow.
But
Yeah.
not commercially available in New Zealand yet. So that actually will help patient even not have a colonoscopy. If the stool test is negative, it makes your risk of bowel cancer so low that you can actually risk not doing a colonoscopy.
Yep.
Colonoscopy does have a miss rate of about 2%. It's not 100% foolproof. And CT scan is about 2 to 3%. So it's roughly the same for bowel cancer only, detection of bowel cancer. The good thing about colonoscopy is that you have to take the bowel prep. So if you have bowel symptoms, you're youngish, and you just want to see whether I've got SIBO, then actually it treats the problem at the same time.
Wow. Yeah, and gets rid of
there's one other benefit, because the CT scan does not give you bowel prep, which doesn't have that additional benefit. But it is much better tolerated. You're quite right. In your mum's case, I think, who's 82, who's a bit weak from the E. coli infection. As you know, E. coli is the biggest generator of LPS, which knocks you for 6, because that's why E. coli infection is so potent. You get water infections from E. coli, you get water infection from Klebsiella. If you get E. coli, you suffer much more.
It was terrible. Like, and you said hers was a particularly bad strain of E. coli. And mum unfortunately ate something at a cafe somewhere and ended up with this E. coli in December, and was basically in bed for 6 weeks and very, very ill. It was touch and go, that bad, and bleeding and all sorts of things that were involved. And she'd had a history of bleeds last year as well, which we believe are coming from diverticular disease. We don't quite know. That's why we're going to have a look in there and see what we can find, although we won't be able to rule out a lot of the things, because we're only doing the colonography and not the colonoscopy because she's too weak. But I was shocked at how bad an E. coli infection was, and it actually really, what I was surprised, because I was throwing the bus at trying to save her and keep her out of the hospital and keep her going for that period of time. And we did do intravenous vitamin C. We did do, I had quite an extensive regime of probiotics and tributylin, like butyrate supplements, and prebiotics, and everything known to man. One of the ingredients I'm super excited about is called immune defense protein, which is a derivative of a bioactive, over 50 bioactives from milk bioactives, actually. So and this has been shown to improve the immune system in the gut, the leaky gut situation, and I saw for the first time her lymphocyte count go up after taking this. And now we're on that, and there's been clinical research about all of this. So immune defense protein, put that on your list to have a look at. I can send you some data on it. And another one called Immunel, which is also another one of these fractions of the whey protein, and it comes from colostrum. So and this has been super beneficial, along with a lot of other things in the mix. I've also used peptides. Have you come across peptides in your journeys?
Well, peptides, actually, we produce a lot of them ourselves. And we were talking about elastase earlier. Elastase itself is a peptide. So there's a lot of them. There's amylase. I mean, there's a whole host of them in our system, and you're quite right. You got insufficiency of peptides in your body can itself cause dysbiosis.
Mm-hmm.
So yes, peptides is a very important. So peptide supplement. I mean, I have to be more objective in as a clinician, I guess. So we would probably only give peptides to patients if they're proven to have deficiency of peptides,
Mm-hmm.
rather than give to you when you've got normal amounts in order to boost the dysbiosis. That's something we haven't quite done yet.
I'll put it on your radar. There's a couple to look into. That one's called BPC 157. So these are there's orally available peptides, and then they're injectable, so subcutaneous injections. So when I'm talking about peptides, this is more in the States where it's used more extensively. And one of Mum's doctors that I have her under is a longevity specialist in Boulder, Colorado, who's an expert in peptides. So we have used BPC 157 in her, and another one called KPV, and I've forgotten what the acronym stands for. Again, just to try to improve that gastrointestinal, that permeability, the gut barrier health. So I think peptides is a space in general that's not well known in New Zealand, and using them, as subcutaneous injections mostly, but getting a little bit off topic. So what, coming back to the microbiome, is there, when we're looking at the breakdown of all the different bacteria in there, can we influence that by the foods that we are eating? What's your take on the nutritional side of things, without going into which diet's the best and so on? But what's your take on, if we're eating lots of junk food and processed food, is that going to impact our gut?
I'm sure it does. I don't have any scientific knowledge why it does. So if you think about gut health again, so the IgG, secretory IgA issues. So some people are, for example, intolerant to certain foodstuffs, and we don't know who's intolerant to what. That's all down to our genetic makeup. If you're intolerant to certain things, and we study this well with celiac disease, gluten is a classic example.
Yeah.
So if you're celiac or even mild form of celiac, you take gluten, your gut is reacting really badly to it. IgA everywhere, to secretory IgA, and making your bowel really leaky, causing all sorts of symptoms in your bowel. Similarly, if you take on a foodstuff that you are intolerant to, rather than, I wouldn't use the word allergic, intolerant to, and body will react to it. It reacts to it by making your again, chronic immune activation, leaky gut. Even though you've got normal microbiome, that can still leak out. And then when you leak out, you're going to have to replace, and then over time, it's going to be dysbiosis. And it's a vicious circle. Anything that causes function of the gut to be wrong, whether it's medication or whether it's infections or just simply intolerance to food, causes the gut to move too fast or too slow, refluxing the large bowel to the small bowel. These are the causes of dysbiosis. And then we give people antibiotics to treat this, and we give them anti-acid medication to treat that.
Oh, yes.
These things, then sometimes we give painkillers which slow your gut down. So it becomes multifactorial causes of dysbiosis. So yes, I would say food is definitely an important factor in dysbiosis, but to know what's causing you as an individual is very difficult to know. The reason why we try low FODMAP diet and the reason why we try low carb diet is really just a basic theory of stopping bacterial overgrowth. But you're right, it's so food intolerance is actually a very important topic in that etiology of IBS.
Yeah, we've got a family history of celiac in the family, and that's definitely one of the issues. And I think probably all of us could benefit from going gluten-free. Not always an easy thing to do, but I don't think it's probably good for anybody, the gluten side of things. But the celiac, it's very concerning. I've got a brother with it. For me, I'm very concerned about what could happen to him further on down the track because of this immune activation, because of the leaky gut that he's likely in. He's strictly gluten-free, but even when you're gluten-free and celiac, there seems to be there's some doctors who are, and this is controversial stuff, but saying that there's even glutens and things like rice. There's different types of glutens. There's different things that like go grain-free, and that's controversial, but it's definitely an area where there needs to be more research done, and it's concerning when you have something like that you don't end up with, the things like cancer and that type of thing, or this immune activation, autoimmune diseases.
Well, I mean, talking about celiac, now we know celiac disease, and as a good example, because there's a common food type intolerance, if you like, and chronic celiac and chronic gluten use, if you're intolerant to it, it stimulates the gut chronic immunosuppression in the gut. And we know now gut lymphoma of the gut.
Wow.
Almost not, I'll be careful what I say because I haven't got enough scientific evidence, but certainly we know there's an association between gut lymphoma and celiac disease.
Wow.
Because of the chronic inflammation in the bowel. I don't know many other conditions that give you gut lymphoma. I'm not talking about the other type of lymphoma, but gut lymphoma. So there is an association.
Yeah, that's very interesting. I have to look into that one a little bit more, especially since we've got lymphoma in the family as well.
I think they're different types of lymphoma. So
they can't go from one to the other.
But I'm talking about gut. I'm talking about gut, what we call MALT, MALT, because it associates a lymphoid tissue.
Lymphoid tissue,
so MALT for short, MALT. Yeah.
Wow, okay. And what about something that's come on my radar recently? I did an interview with Dr. Christine Horton, who is an expert in something called sulforaphane. I don't know if you've come across sulforaphane and its activation of the NRF2 pathway, which is your sort of antioxidant defense mechanisms, your endogenous sort of antioxidant defense mechanisms. And this has been really interesting to study her work. So putting sulforaphane, or you don't put sulforaphane, to be completely correct, you have the precursors, glucoraphanin and myrosinase, which comes from your broccoli cruciferous family. And this upregulates, I think it was something like 200 genes and over 2,000 enzymes are impacted by this pathway. And that can be very, very beneficial. It might be interesting for you to have a listen to that podcast that I did with Christine. And she has something called the GEM protocol, which I've been putting in myself. I've been using this because sulforaphane is quite good for many things, including cancer prevention, and has been a part of Mum's protocol for a while. But yeah, the NRF2 pathway, have you looked into that one at all as in regards to gut health? Or
no, I have to confess that I'm not familiar with that pathway so much.
Yeah, it's a pretty obscure thing to ask, really.
It's obscure, but it's just these studies have only just been out in the last 15 years.
Yeah.
Microbiome talk and these pathways, the obscure pathways that actually, again, promoting general health, organ functions. If you've got good organ functions, your longevity is going to be better.
Yeah.
And your immune system is going to be better and stronger. Rather than fighting a constant battle. So I guess, that's one of the pathways that you talked about must be part of the whole thing, but I'm not familiar with it.
Yeah, it's quite an interesting one to, and I've been enjoying sort of learning about that. The last thing I wanted to touch on today was gallbladder, because so many people have gallbladders, taken out. And what are the implications of losing your gallbladder or having a less than optimal functioning gallbladder in regards to your gut health? What is the gallbladder involved with that?
I think it's a balance between risk of having gallstones or the gut health. I mean, when we're designed to have a gallbladder, it has its function, it has its purposes. I think if you got to the point where obviously your pain has become unbearable because of gallstones, or the fact that gallstones are causing many complications of organ dysfunctions, damaging the pancreas, then I think it gets to a point where surgery really is indicated because, you're damaging the body. But losing the gallbladder, thankfully, in the majority of people, there's no noticeable symptoms. They tend to just be well and get on with life. A few individuals, it affects the amount of bile going to your system. You're absolutely correct. So some people who lost the gallbladder can have too much bile directly from the liver, not being focused or concentrated on by the gallbladder, because it's gone, straight into the gut. And that bile can, again, cause dysbiosis.
So it could be too much or too little of
too much, exactly. It's a good balance, and the gallbladder actually makes it right. So it concentrates the bile and only release the amount of bile to digest your fat in your diet when you have a fatty diet. You go and have fish and chips, it stimulates the hormones in your stomach. That tells the gallbladder to start squirting, washing up liquid, if you like, wash up the fat so that you digest the fat. And that digestive fat has minimal effect on your microbiome. But if you've got pure fat, undigested, or you get too much of bile, diluted bile into your system, the gut just doesn't get it, and that's where the bacteria go haywire, and that's where dysbiosis comes in, and that's one of the causes of dysbiosis is having a gallbladder surgery. Now, I wouldn't want to say this to put people off having surgery, because you have to. Yep. Yeah, you have to. And I think if gallstones are causing complications in your body, then I think that warrants surgery rather than worrying about the complications of that, these long-term issues rather than complications of surgery. That's right. So counseling is important. As a surgeon, of course, I promote gallbladder surgery because I think complication of gallstones, the risk, the benefits outweighs the risks.
And they're certainly painful. I had one 20 years ago. It was not a pleasant experience.
No, and some people have it weekly.
Oh,
they
God.
can't live like that.
No, horrific. It was very, very painful. I thought I was dying. The last thing, proton pump inhibitors and antacids and, meprazole and co. I feel these are often given out for too long. These should be short-term fixes if we really need them, unless we've got an ulcer or something. But do you see downstream negative side effects of being on proton pump inhibitors for too long?
Anything too long is always not good. So yes, again, proton pump inhibitor is well known to cause dysbiosis as well. The acid that we produce in the stomach is designed to destroy bacteria, the bad ones.
So they're your first line defense, really, isn't it?
Yeah. So by causing, and it's well known now, too much proton pump inhibitors, or even in hospital, has an increased risk of Clostridium difficile infections. That's well known. That's one of the drugs that we talk about. Politically, Clostridium difficile is because it's infectious in a hospital. It causes problems and long hospital stay. So they test for that all the time. And over time, they realize that actually there's an association between proton pump inhibitors and Clostridium infections. Same principles. You're not using your body acid, the appropriate amount to keep the control of your classroom. The classroom's going to go wild. Go haywire. So yes, so that affects dysbiosis. It's difficult because, like, for example, if you're at risk of ulcers because your lifestyle is stress, you're because you're prone to ulcers, and you get a bit of pain every so often, how can we treat you? We can't say to you, go and do yoga and give up your job and sleep better. It's difficult to change the lifestyle. So the easy way out for all of us, I'm not saying it's the right thing to do, is to give you PPI, the proton pump inhibitors. And so that's why we give so much of it and for so long. There are some people who do require long term. There's certain conditions that you do need long term. But I agree with you. There seems to be a common drug that we give away maybe too long and too often.
And understanding also the nutrient deficiencies, I think, that come along with proton pump inhibitors, that, Off the top of my head, I can't remember them all, but there was B12, I'm pretty sure, is one of those. And it can also interfere with the nitric oxide enzymes in the body, which of course can have deleterious effects on the whole cardiovascular system. So something just to be aware of, if you've been on them for 4 or 5 years, maybe have a conversation with your doctor. Do I need to be on these still, or is there something else, or do I need to check for nutrient deficiencies because of these types of things that you're on?
Right.
And the very last thing, because I did just think of something else, fecal matter transplants, FMT transplants, hot topic at the moment, and have been for the last few years. Quite exciting research in the anti-aging field, even for FMTs, and there are companies now starting to produce these pills, basically poop from other people that are in ideal health. What's your take on FMTs and its use and
Yes, I mean, I support it. FMT is actually available where I was trained in the UK for too much of the wrong bacteria and Clostridium. We're just talking about Clostridium difficile, and that's a well-known treatment for it, because Clostridium difficile is a bully.
Yeah,
it's a bully. It kills the good bacteria. It stays dormant. It just kind of pushes everybody out. And yes, you can give bowel prep to treat that, but fecal transplantation actually does treat the problem. It actually resets. You're basically giving the good bacteria an extra army to fight back. And so yes, that's a well-known study. But whether it gives you longevity, I haven't got enough data or scientific reading to back it. But certainly is a topic which I think warrants more extensive research. Definitely.
Yeah, and even just from thinking about it, if you are giving back a good microbiome as you age, because the diversity of the microbiome goes down as you age. That's one thing we sort of know. As there's been studies, I can't quote which, but on centenarians, and often they have a very diverse microbiome, compared to other older adults who don't live as long. One of the key factors that the centenarians have is a microbiome diversity that is very rich. And I think it got interesting implications for longevity, because that's what I'm very, very interested in longevity and age reversal and all of that sort of science that's going on at the moment. But I do think there are some horror stories with FMT as well. So I think who is the ideal donor? Is that someone like from a genetic point of view, or maybe you had a certain microbiome and the one that you got given isn't actually compatible with you? So I think there's risks on both sides of the fence. But for Clostridium difficile, I have a friend in Australia who was very, very, very ill, and her son was very ill with developmental disorders, and it turned out to be C. diff, and FMTs were the answer. So very, very interesting. Professor, you have been wonderful today. I'm so glad to have had this time with you. I'm so grateful. Are there any sort of parting words that you'd like to leave the audience with? Sage advice as to how to live your life and what you should be looking at. Any sort of advice there?
Well, I mean, that's a big closing statement.
Yeah. It doesn't even have to be in the guts. It could be just in general.
No, that's right. I think, as I said, in terms of microbiome or gut health or digestive health, the whole, like I said, in conclusion, everything interlinks in your body.
Yes.
Anything from being happy, anything from being living healthily, they're all interlinked. It's not just like looking after your heart doesn't mean you don't look after your gut. And looking after your mental health actually can promote longevity for many, many reasons.
Yes.
And exercise, the reason why exercise is good for you is not because it keeps your body fit, but actually it generates the right hormones. It gives you happiness. It gives your gut better health. So they're all interlinked. So I think living well in general is very important in longevity, not just looking after individual organs,
couldn't agree more. I think
Yeah.
that holistic, for the want of a better word, is looking at that interconnectedness, and this is really great to hear coming from you, because like when you do it, when you deep dive into one particular focus of medicine, it sometimes is missing from the conversation, but that is connected to that. If you're looking at the heart, the pulmonary system is gonna go with it, and
That's right. It
all of that. Yeah,
it's one body, not one system.
One body. The brain is connected, and the gut is so influences the brain, and I think that and maybe that's a topic for another day, is the healthier gut will be the health of your brain. If you've got a leaky gut, you've probably got a leaky brain, and your moods and your depression and all of these sorts of things are very, very much tied in.
That's well studied. That's well known.
Yeah.
That's right. So stay well, I guess. That's my message.
Wonderful. Thank you, Professor. It's been wonderful having you.
No, thank you. It's an honor.